Good morning, everyone, again. This is Tracy Berardi, Program Manager, BPM Plus Health. I work for the Object Management Group, the standards body that helped to launch this great community 1 year ago this month. So you're in our first session of the e-workshop, and we have 3 speakers for this session. We'll start with Ken Rubin, our Executive Director, Shane Mcnamee, Chief Medical Informatics Officer, and then Dr. Anna Orlova, who's co-chair of the Academic and Professional Education Working Group. So this session is about an hour with plenty of time for questions, answers, commentary throughout. So feel free to take yourself off mute at any point. And why don't I turn this over to Ken to get started.
Can everyone hear me okay?
Yes.
All right, yes. Terrific. Good morning, everybody, or good afternoon to those who have joined us from overseas. It's my pleasure to be with you this morning. If I could ask everyone to mute your lines if you're not speaking, that would help us with the audio. So thanks for that. This particular session is the year in review. So we launched the community, as Tracy mentioned, a year ago this month. And a tremendous amount has happened. So I hope out of this hour is for those that are perhaps intermittently following us to give you an update on really what's happened within the community over the last year, and in particular since the June workshop, and really to hear a diversity of viewpoints about what's happening across the community. So I'll kind of set things up and give a little bit of the background for those that are joining us for the first time. Then we'll hear from Shane Mcnamee, who is our CMIO, and then Anna Orlova, who's one of our work group co-chairs. And then we'll have at the end for a bit of a wrap up and for your questions. If you have questions as we go, please drop them into the chat, and we'll do our best to address those as we go. And then, as I mentioned, we'll have time at the end for a little bit of Q&A. So without further ado, why don't we go ahead and jump right in. Next slide, please. So what is BPM Plus and this community really all about? If you look at the discipline of health, processes and best practices are changing. They're ever changing, especially with what's been happening with COVID. I think it's never been clearer how urgent it is that healthcare organizations can evolve knowledge and then bring that knowledge to bear as part of day-to-day clinical practice. I tend to focus on the clinical side of things. I should mention I'm executive director of BPM Plus. I'm informatics architect. I've been involved in health informatics for about 20 years and have been involved in the standards community for about that same amount of time. So heavily involved in this, health interoperability space, and that's really what drove us into this community. Every discipline, professional society, et cetera, today uses their own language, and a lot of those best practices, those clinical practice guidelines, are written as digital paper. They're PDF documents and can be subject to interpretation. They can have variants. It can be difficult to interpret. It can be difficult to implement and deploy. And at the end of the day, we as an industry need to do better. I tend to focus on the clinical side. I've got a background working with provider organizations, but nothing about BPM Plus is exclusive to clinical. So these same approaches could be used for advanced directives. They could be used for pre-authorization, et cetera. So how do we collectively apply industry standards in a consistent way to allow for these workflows, these processes to be more effective, to be better shareable, to be machine readable at the point our systems support that? And how do we advance that within the systems that we use? How do we take advantage of commercial tooling to express these pathways and these best practices, and then to be able to promulgate them across institutions and ultimately organizations following the journey of care of a given patient? So BPM Plus, we're a year old now. This is an open community of practice, and I'll spend a little bit more about what that is and what that means. It's supported by commercial tooling, and it's really focused on this shareability aspect. And I think one of the things, if I leave you with nothing else out of this talk, the idea here is that we have a community of of peers, of experts, all working in the space. I don't think any one of us has all the answers, but the idea of the community is to be able to bring that diversity of perspectives together, so that collectively we can kind of think through these hard problems, identify patterns, reuse those patterns, and as a whole do a better job around this space. So if we could move to the next slide, please. So as I mentioned, we're a member-driven community of practice. And what BPM Plus is really striving to do is to create an environment where that collaboration can happen. We've deliberately engineered the community so that the level of entry, the barriers to entry are very low. Our calls are all published on the website. We'll show you where that is. People can dial into a call without being a member. We encourage that. Naturally, members have the ability to do some things like hold leadership roles and so on that regular participants can't. But at the end of the day, this is about getting engagement going. It's about working together to figure out how to solve these hard problems. The community is egalitarian. So we're structuring this as one organization, one vote. So it's very flat by design. We are not a standards body. We are not trying to be a standards body. We will be publishing out guidance, best practices, potentially implementation guides, et cetera, but we won't be publishing standards. Our idea is to consume standards and to be able to adapt and apply those standards to particular situations. As we identify shortcomings and gaps, we'll address those gaps. We're working with the appropriate standards bodies to close those gaps. On the right, you see a little snapshot from our website. We're very fortunate. We have a large diversity of co-chairs and leaders within the community. This is not everybody. We've got ambassadors, co-chairs, sponsors, all sorts of heavily engaged folks within the community. This is just what I had at the ready. But one of the things that's been really exciting is we work very hard to kind of distribute trust within the community and to empower our work groups to do what we think or what they think makes sense. So certainly we want to hear what those opinions are. We want to hear those ideas. We want to hear where the challenges are so that we can take those on. Next slide, please. So how are we structured? The community is structured into 5 working groups. This has been the emphasis over the last year is to really get these groups stood up and functioning. And I'm happy to report that we've hit the 1-year mark and we've achieved that. So each of these work groups has their remit well in hand. They've been convening, some of them very frequently. Most groups meet either weekly or biweekly. Some have met more frequently than that. We've got the authoring work group that's focused on kind of developing guidance for organizations that are creating pathways. We've got organizational adoption and change management, which is looking after how does an institution bring these pathways into the institution and deal with that organizational change. So how do we ingest a pathway? How do we adapt processes internally to be able to use and leverage those pathways, et cetera? We have process automation and enablement, which is focused on the systems and the software that actually execute, build, run these pathways, consume these pathways. We have a methodology work group that's looking at the core standards and how those standards fit together and identifying and addressing gaps. And last but not least, we have the academic and professional education work group, which is outreaching to universities, colleges, informatics programs, medical schools. On the one hand, developing curriculum around this so we can advance this, more systemically, as well as working with workforce development and advancement, professional education, professional societies, et cetera. So that's, very, very quick tour of what's happening. We'll hear more about snippets of this throughout the week here. One thing I will note for those that have been monitoring the community for some time, some of these names are a little different. We've recently done some renaming of work groups. The core mission hasn't changed, but as the efforts have unfolded over the past year, we've gotten better clarity where there are ambiguities and how these work groups fit together, and we're addressing those ambiguities and really sharpening our focus. So I think this is all very positive. We can move forward, please. So in a one hour year in review. Obviously, we can't go into tremendous detail and everything that's happening, but I thought it would be useful to spend a couple of minutes on five kind of big takeaways about what's been happening. So those that are close to the community, these are probably not news, but for those that are kind of intermittent, hopefully this gives you a sense for what's happening and where we're trying to go. So in terms of our priorities and the key efforts, we're really looking to accelerate the focus on adoption and the use of BPM in the market. So we are not intended to be a purely academic exercise. This is not, a purist community. It's intended to be a place to get work. And in that vein, we're taking deliberate steps to engage with organizations that are trying to put in place real world solutions that address some of the challenges that we face as an industry, and expect that to accelerate. So the first year, much of my time was spent in working with the co-chairs and the different work groups, putting some of the infrastructure in place to make sure we had a functioning community. Addressing challenges that came up and clarifying, concerns that were raised, as you would expect in any sort of. We're through that time, and now we can really look forward, and that's one of the big takeaways for where we are at the moment. We're targeting high impact pilots and reference implementations. So one of the things you'll hear about is that we're going to be starting perhaps a new implementation kind of pilot project around advanced directives and consent. That's being led out of our process automation work group. So that's very exciting. We're announcing that today, right now. So that's a new effort. You haven't missed anything on that. We intend to have a working session to do discovery around this and start to frame that project. That'll happen the first week of October, and it's on our calendar. We are working with the educational institutions on a BPM Plus curriculum. And in fact, you'll hear a bit more about a capstone project that was done as part of our academic and professional education group in collaboration with Duke University. That effort is being led by Anna Orlova. We'll hear about Anna shortly, from Anna shortly. In terms of the community itself, we're rounding out the portfolio and getting our own house in order, understanding work groups and how they fit together. So we're starting to have artifacts that cross the boundaries between work groups, and we're thinking through how that works. That's all part of our governance and so on. I'll touch on the governance in a minute. We also have several core specifications that are being advanced: situational data model notation, pedigree and provenance, and knowledge package model notation. So these were all areas that were gaps in the that we're going to be addressing within the standards community, and with the intention of adopting those and leveraging those within our community. A big takeaway from this week is that we're transitioning out of startup mode. So we had a year to kind of get things going. It's going to take us just a little bit longer. I expect we won't be fully out of this until the end of calendar year. But one of the sessions you'll be hearing tomorrow is around our community governance. So we're getting the house in order, formal bylaws, elections, all that is, we'll be reviewing those draft documents imminently, setting up a work group to advance those things, and then instituting those, putting them into practice. January 1 is our current plan. We are very concerned about sustainability and making sure that we are a sustainable community. You'll be hearing a little bit more about our approach to that, the institution of a formal steering committee and how elections will work for that. This creation of a partner tier member, which would be, kind of a high dollar contribution to have increased influence and help in the strategic direction of the community, with privileges and responsibilities that would go with that type of an obligation. And then the last kind of big takeaway is we're starting to get more proactive working with peer organizations. So we've had endorsements and have been collaborating with the likes of HL7 and AHRQ for some time. We're starting to see that move to the next stage. A Tiger team is currently working through the relationship between BPM Plus and, for instance, clinical practice guidelines on fire. And we expect to do more of that type of outreach proactively to make sure that we're well positioned within the market. Next slide, please. So very quickly, I want to get to Shane. If we could just go ahead and click out the build here. Um, we're starting to show some substantial growth within the community, which I'm really viewing as an impact that we're having. 2,700 unique visitors per month, and we've got 2,500 people on our lists. The fact that we're closing in on 5,000 on-demand views of our content, webinars that have been conducted, education sessions and seminars such as this one have been viewed, an awful lot of times. We've got 750 downloads of our field guide, which is our seminal document. And keep in mind that really it's only been a year since we've launched this. So from where I sit, I'm very happy with the progress we've made over the year. That doesn't mean that we're satisfied. We're not. There's still a tremendous amount to be done, and an awful lot of good work that we need to broaden the impact of. But in terms of the way we're tracking, I'm very happy with the trend, and the focus this year will be on modest growth. So now that I think we've kind of got the core house in order, we want to grow the community, we want to grow our impact, we want to grow our relationships, engaging more with the likes of HIMSS, for instance. We're in discussions about advancing BPM Plus into some of the HIMSS Connect-a-thon work, et cetera. Next slide, please. So with that, why don't I pass the torch over to Shane. So we're thrilled to have Dr. Shane Mcnamee, who has joined us as CMIO. He's been in this role for about a month, maybe just a hair over a month. So without further ado, Shane, the floor is yours.
Thanks, Ken, and welcome everyone here today. This is a really exciting day for a lot of us. We've been pushing this boulder uphill for quite a few years together, and to be able to see that BPM Plus Health has hit its first birthday. I promise everyone never to sing happy birthday out loud, but I really do want to recognize the fact that this community is built on service. No one here is getting paid for this. And what you see when we have strong leadership like we've had with Ken is that a tremendous number of people, professionals from across our industry, are coming towards this community, both by themselves and with their organizations, to serve. Which is really uncommon anymore, it feels. And, I really wanted to start off here today and lay that out there as the fact that what we're doing here within this community isn't advancing ourselves, isn't advancing our organizations, isn't reaping the power and the glory of being part of a standards organization. But better yet, we're laying the groundwork for the next generation of healthcare, for the healthcare for our children, God forbid, our grandchildren. And it's incredibly fulfilling and incredible to see how far we've come in a very short period of time. So for all of those who are new with us here today and just joining, we look forward to welcoming you in and bringing you in and helping you understand where we can move this. We look forward to learning from you. For our new members, American College of Surgeons and some other organizations, thank you for believing, and thank you for coming into the space. And for those who are just dipping their toes in now and checking out what BPM Plus really is and what it can do, we hope that you find the same, the same value that the rest of us have as we've come forward into this. And I can't wait to celebrate 2 and 3 and 4 and 10 and 20 along with everyone else. So that was me singing happy birthday. That's what you get for that. Next slide, please, Tracy. So, and you can just click through the numbers. I just wanted to show this again, and I know Ken talked through it already, but that's 1 year. And you look at how big things change over time, right? The impossible things, this impossible idea that there actually could be a standards-based process orchestration layer that sits above EHRs and other health IT machines and what have you. As Dr. Opelka said not long ago, this is no longer a technology problem, but this is now a business problem. But it's a business problem that's hard to solve, right? But the way that we do that, and I see John Scott's question, are there any EMR vendors out here yet? The way that we do that is we continue to pull people into this community, singular sense of belief in terms of how we can move this. And we move markets that way. We are the consumers. We can demand something different, something better, something in an approach that actually can improve the four metrics of quality at the same time in healthcare. I'll get to that in a moment. So never underestimate the power of a well-formed group, particularly one where people are coming to serve a greater good than themselves, as we are here, rather than just to serve their own ego. So good on you, Ken, for leading us forward in this. Next slide, please. So why now, right? Why would things change, right? Many of us have worked in health IT for a very long time. We've seen an era in which patient care is more distracted across many organizations. There's an explosion of health information technology that doesn't speak to each other. The boundaries and the barriers to care between organizations or payer systems seem insurmountable. Why do we bash our heads against these walls now? What can we hope for the future that changes things? The beauty of the age that we live in right now, from information technology space, is we now have these amazing things called clouds, right? Not the one that sits above me in Cleveland at all times, but the health information technology clouds that can bring safety and security to data, but also our natural integration environments, moving us past client servers that were built into old hospital rooms that were barricaded off and not meant to integrate into anything. Healthcare is now modernizing to clouds. And as that happens, that offers a tremendous opportunity for orchestration across. And then FHIR comes along, right? ONC and CMS in the United States, at least, are pushing towards that. And there's obviously a natural or an international press towards it to start to clean the data hygiene issue. So you can start to take data from many different places about one person or populations and make sense of it and understand it in event-driven models in the clouds, but you get to what? And we had these conversations with people in a long time. So what you've gotten to FHIR, right? So what we now have clean data at RESTful endpoints like every other industry. For healthcare providers and patients, we all know the fact that our data is only one part of the healthcare equation. As a matter of fact, it's probably the less important part. It is the thing that happened before now. Our data is just what happens up to the point of today. We can't do anything in terms of improving our health outcomes by looking at yesterday. But our data doesn't inform necessarily the processes in terms of how we move forward. And that's where BPM Plus Health obviously comes in, is reaching that level of process interoperability and reaching that level of the ability to deploy best practices very quickly into workflows and to learn from them so we can start to build air traffic control systems for healthcare that we all own, not just a single EMR vendor. So the industry has changed. The marketplace is changing very rapidly. And there's a very clear need for a technology approach like we are bringing out with BPM Plus Health. So the walls themselves are beginning to crumble. Next slide, please. One of the things I wanted to talk through quickly is a clinical steering committee. We've picked this up and kicked this off a couple of months ago with the purpose of answering the so what? So we're going to apply, processes, healthcare, So what? How does it actually help healthcare? How do we prioritize? How do we set frameworks and priorities so we can strategically move this forward? So the clinical steering committee is in its infancy right now. There's a couple of us on it. We're going to be opening that up in terms of the membership associated with the governance sessions that come out here soon. And I want you all to start to think about who in the community out there should represent in the clinical steering committee. I want to tell you one of the things that the clinical steering committee is not. It is not a bunch of doctors sitting around talking about healthcare. Right? Clinical steering committee is meant to represent the main stakeholders within the clinical moment. On one side is the patient, and on the other side is the clinical healthcare team and the other folks that support that. So it is a place where we hope to have many voices to help, really guide towards population health levels of improvement for care. Anyhow, you'll hear more about that as we come forward. We're beginning to coordinate with other organizations and think to yourselves out there, is this something potentially I would like to be part of? Or maybe you have colleagues out there that are in other specialties in healthcare in different ways, clearly need, as usual, more nurses than doctors, because nurses have a tendency to see the outcomes in more of a global, holistic perspective. We need representatives from different components and different roles across as well. So you'll hear more about this coming out, but really our purpose here is to provide a guidework, a framework, so we can start to build towards a future where we actually see BPM Plus Health affecting value-based care and quality outcomes. Next slide, please. So how can we, right? So when we step back, and the first question we asked amongst this group is what should we be looking at? What's in the distance, right? What should we be moving towards? We can debate this at length, and we've done this already, but there are really only 4 high-level healthcare quality metrics out there. There's effectiveness. Effectiveness is both the make sure you do good for the patient, you have better outcomes, but also make sure you do no harm. So it's safety and improvement. There's efficiencies, critically important to work through efficiencies, both from a cost perspective, but just simply from the number of hours that clinicians have to spend tied to the computers in front of them rather than in their patients. There's access, specifically access to care for patients, easy access to information and process for providers, and then there's satisfaction. Those are the 4 high levels. I remember talking with Denis Gagne, who's on the call here today, who's been a mentor to a lot of us as we've come into this. And I remember hearing a talk a few years ago where Denis had the 4 on an axis, north, south, east, and west, and described the fact, and as a quality health implementer over time, I felt this is that you can go ahead and take and do your best to improve 1 or 2 of those. You can improve effectiveness, but it's like the little blanket in the middle of the wintertime that you have just enough that you can pull up and cover your nose, but when you do it, your feet are cold, right? So you can make your systems more effective with the current technology, but generally they become less efficient because your effectiveness comes from burdening healthcare providers or bringing more, resources to bear on one place and taking them from another. Similarly, with the rest of them, is you can generally, with a well-meaning group of people, you can look at your outcomes across your programs or whatever it may be, and focus heavily on one of the top 4, or maybe 2 of the top 4. But it's incredibly difficult because of the technology barriers that we see currently to hit all 4 of them at once, right? So that's the beauty of automation, right? Automation in its nature makes things better, faster, cheaper, and feel better using the theory of constraints. So read up on the theory of constraints on the side, but it is a natural approach as we begin to bring out best practices, constrain the possible in terms of what can happen and how people can flow. We can begin to affect all four of the high-level quality metrics at the same time. And that's revolutionary for our industry. Next slide, please. So, bending the cost curve, right? You're probably sick of hearing from me on this, but healthcare costs are going up at an unsustainable rate. Healthcare quality is not improving at the same. As a matter of fact, it's very still difficult to tell in abstract quality metrics from individual patients or populations over time across organizations. To really understand how chronic diseases and how our resources that we're putting into there is dropping. So I see the cost curve in healthcare as having two components. One is the number of actual dollar signs costs, but the amount of human suffering. So the longer we let healthcare conditions go on and don't detect risks early, the more human suffering and the more it costs over time. It's very simple. So how do we move from what's on the left there, right, from plane crashes, right, where in healthcare, oftentimes, we don't even know about risk data, high risk data, or something has happened that should click us off to look into the patient or put them in a new stratification layer for across the population, right? So somebody's been in 2 emergency rooms over the last month for depression and suicidality. We often don't find out that things have gone wrong until there's been a suicide attempt, right? Or the kid who's in, inner city who's got asthma and keeps going to different emergency rooms that aren't connected to the same systems. And we're not recognizing the fact that this individual is, has environmental contaminants and other social determinants of health that's negatively impacting, his work through school and everything else, because we don't see the events as they happen in real time. We aggregate them on the back end as part of claims data. We run most of our risk adjustment systems still in healthcare from the bills, literally the medical bills and the data that comes out of the medical bills 30, 60, and 90 days after the event has occurred. That's a tremendous amount of time to wait to try to bend that cost curve and to mitigate that risk. BPM Plus gives us the capability, because it's an event-driven architecture. It's built around start events and end events and the ability to move in between to be able to manage those, to get upfront early on and bend the cost curve, and using risk detection, stratification, and mitigation using best practices. Next slide, please. So, a challenge for our community and really for healthcare at large. I want to lay this out here today. I went through some of this already. The problem, healthcare costs are going up. Quality is still really unknown. Value-based care is really hard to prove and pay for and understand that risk. Our risk data in terms of understanding what's happening, something critical is takes the actually have an effect on it. If you're not on mute, could you please mute your phone? Thank you. Out there. Perfect. Thank you. So a solution to this, how do we begin to attack chronic health conditions and other emerging risks in a way that makes sense from a population health perspective, where we can envision air traffic control systems, i.e. understand the planes that are in the sky, understand the planes that are in the sky that are in trouble, so we can help them before they crash and cost a lot of money and a lot of human suffering. So how do we move towards this? BPM Plus Health is a great way to do it. Detect and mitigate risk early and start to work towards this virtuous circle of identification of best practices and rapid deployment into workflows. 17 years is too long to wait to be able to move best practices into healthcare. Healthcare providers, as much as people believe that we know many things and know the answers to certain things, we don't. It's hard to stay up on the literature. I remember when I went to medical school, I was waiting for the Golden Book of Answers, and I thought they were going to give it to me when I went there. I went there, and there's no Golden Book of Answers. There's no right way, it seems, to do things other than the practice patterns that we've had in the past. So how do we advance truly into a learning health system? Process management. So the open challenge for our community coming over the next year, and I'm going to be pushing this out in a lot of different ways. God forbid, maybe even doing some fundraising to get a little kitty together for a connect-a-thon purse, is to use BPM Plus technology to start to look at novel ways to bend the cost curve for chronic health and other conditions, using obviously BPM Plus, FHIR endpoints, CQL, CDS, you name it, to develop reusable public health risk detection and stratification patterns. We can get into that a little bit more. I didn't want to bring too many of them out here, but there's some very basic patterns that we can begin to form around either conditions or populations for risk detection and risk stratification over time. And then demonstrate, hopefully by this time next year, demonstrate these capabilities around risk detection, right? And that's the key to value-based care. Early risk detection, demonstrate these capabilities in Connect-a-thon, and hopefully in some live deployments of our technology, approach within the market space. So you'll hear more about that as time comes on, and as Ken noted, we're working towards some connect-a-thons and what have you, and those are some of the boundaries potentially we're going to be placing around them. Next slide, please. So this is my last one. Committed groups of people who work to a greater good have always been able to shift markets, governments, technology, the state of the possible. We're at a perfect point in time right now. Some of it's pushed forward by COVID, and it's exposed the boundaries and the challenges within our healthcare system. Being pushed forward, obviously, by regulations for interoperability and this recognition now that process and good process across organizations is what we need to begin to tether down the costs and improve the quality of healthcare. So I've said it before, but now is the time. You are the people to do this. We deeply appreciate you coming forward and serving in this community with us. I've said this before many times as well, as this is all in addition to our day jobs, but we all have a little bit left of ourselves, something that we need to believe in, that we can move towards a greater good. I would ask you to take that part of you as a technologist or as a provider or whatever else you represent here, bring it forth to Ken, bring it forth to these communities, add to the water behind the dams that we're bringing forth, and we will watch healthcare change in front of us because of our efforts. So it's a pleasure to serve beside you, and we really look forward to the activities coming up over the year. It is my absolute distinct pleasure to introduce Dr. Orlova as well, who has done a tremendous body of work over the last year in BPM Plus Health, which she'll describe in a moment, but I'm a huge fan of what you're about to see because of the content, but also because of the approach of bringing up and training people behind us and recognizing the art of the possible. So have a great day. We've got a great conference here ahead of us, and thanks everybody for your efforts and your energies.
Thank you, Shane. And it's my honor to share with you this newborn that I just would like to introduce to you today. And this is the first presentation of the Academic and Professional Education Committee, where I'm calling it newborn because, in fact, we formed this committee exactly 9 months ago. And today, I believe what you're about to see could be very encouraging that we have here the opportunity to empower both end users, IT community, and informatics community with the particular efforts to implement BPM Plus, and with the ultimate goal to improve usability of electronic health record, as well as inform the future applicability of artificial intelligence and all other new technology, digital twin that may be coming. So you see here the website screen of our committee. That's the marketing spiel right now, because I hope after this session you will be able to join us. So as I said, and on the next slide, Tracy, please, you will see some of the teaching artifact that we were able just to shape during this 9 months period. So we started, of course, with the strategy document to get a consensus of who we're teaching, why we're teaching them, what we are presenting them in our educational materials. And right now, our strategy document is in the final stages of review by the BPM Plus community. And I invite you tomorrow to our session just to see what this feedback was, so that the strategy document could be just could guide us moving forward. And in this strategy document, one of the first activity was just to identify what we're teaching and what would be our teaching artifacts. So that you see them here on this list based on BPM Plus methodology. We will be translating the clinical guidelines and best practices in the business cases, and in turn in the use cases such as solutions based on the standardized clinical pathways, standardized workflow and data flow using a particular standards for representing this workflow and data flow requirements, and eventually selecting standards that would be needed to enable applicability of this requirements in the IT products. We also are in the process of identifying the content management tools that would help us to automate this 1 through 5 process. And we also inviting you to help us with identification of the standards, joining our these tools and joining our effort if you have any, so that we could actually teach through tools, not through this endless Word documents that we are been producing in the past. I would like just to share a few slides with you in a way how we were able to pilot test these artifacts. Tracy, could you just please jump to the next slide? And this is this capstone pilot project that Ken helped us to arrange in the partnership with the Duke University School of Nursing, the informatics program. What you see here, this slide and few slides that follow is actually the slides from the presentation that we're developing for the American Health Information Management Association presentation in October. And I will walk through a few slides here to show you how this teaching artifact been tried in the capstone. We started this capstone in June. We finished it in August, and on the next slide, you will see how we begin in our process. So we started with identification of the problem. Students selected particular child sex trafficking as their domain of interest. We identified particular placement within a healthcare organization, emergency department, where we would like to try some IT solutions to be developed. The next slide is showing you how we translated the business requirements into the use case workflow, identification of child sex trafficking victims in emergency department. But what important here that we were able to generate this flow of events and identify the particular data collected. Next slide, please, during this particular events. And from that description, we were able to select 5 standards that are relevant to representation of those data categories that we identified. If we could move to the next slide, you will see there how students were able to model the workflow in the human end user animated diagram, but also in more formal business process diagram based on BPM Plus notations. If we can go to the next slide, then you will see that as the result of this project, we are right now publishing this report that students authored, and we were able just also to mentor. This report right now is available on our website, so you could look at what's there and how this could be the example of one of the deliverables of our BPM Plus community in terms of bringing students from other universities working with us in the future. And on the next slide, you will see our plans. So we are thinking about developing this business use case portfolio using the methodology that I just shared with you. And the list you see here is based on our committee members' interest and expertise. And on the next slide, you will see how we progressed in developing this methodology of and teaching artifacts. So we presented it first at the meeting, BPM Plus meeting demonstrations in June. We collaborated with Mobilizing Computable Biomedical Knowledge, which were not only us, committee members, but also students were able to present their project. And now, as I said, we're preparing our presentation at the AHIMA convention in October. AHIMA convention in October is a very important milestone for us because so far we've been collaborating with academic institution, Duke, Johns Hopkins, Tufts, who helped us just to shape this artifacts that I'm just was showing you. And Mobilizing Computable Biomedical Knowledge is also more like academic and research community. But AHIMA brings us into healthcare organization, into professional development effort, where this activity on business process management standardization are extremely important, especially in the programs such as clinical documentation improvement that exist in every healthcare organization. And we believe that this could be our channel to move that approach from the academic settings into the working environment. And you will see here our next steps in terms of collaboration, academia, professional association work. And of course, we are recruiting new members. We need you to critique our current approach. We need you to recruit more students or professionals to try our approach, but we also need you to teach the artifacts that I was talking about in your organizations and other health information community. And on the next slide, I just to show you that please participate in our effort. We, as I said, need you because it's through the growing membership we will grow both in content as well as in adoption. Thank you so much. Ken, back to you.
That was terrific, Anna. Thank you. So we've got about 10 minutes left. So I think I've been tracking the questions in the chat, trying to do that. There's a couple of questions that came up of late regarding the implementation of BPM. So there's a question, give me a second here, let me get there, about executable instances and whether we have any executable pathways that have been done out there. Maybe I could direct that question to Jane Shellham from Mayo, if you're willing to respond to that. Jane, are you able to come off mute? All right, we'll ask her that maybe there's a problem with the mute, so we can have her respond to that in the chat. Also, for those that have an interest in this, there's kind of a detailed authoring session by Davide Sotara, who is part of that same project team. So I would encourage you to dial into that session, and you could probably get some more detail. So I guess there's another question. When we mentioned new partnership level for high dollar contributions, do you anticipate a less expensive category for smaller organizations such as startups? So Tracy, do you want to spend a second and maybe you could pull up the website and talk about membership and how we've stratified that today and maybe just tease where we're going?
Yes, let me share my screen again here. Happy to. You should see the BPM Plus Health website. Excellent. Let me move this out of the way. Sorry, the WebEx. It's in the way of my link. There we go. Go away. There we go. So under Join BPM Plus Health, there's a membership page, and the way it works is annual. Oh, can you hear me? No. Okay. So the way it works is it's an annual membership, and it's based on the nature and size of your organization. So for the startup category, for example, it's $3,000 annually, and here is where you can see the different tiers of membership. And actually tomorrow in the afternoon when we have our governance session, we'll talk a bit more about the benefits of membership and the stratification between our steering committee, clinical advisory committee members, and then participants. Because as Ken said, we launched this community, keeping it open, for participation, and we want to keep that door open as part of our growth and participation strategy. So we'll talk some more about that tomorrow. But for organizations that would like to join as members, here's where you'll find that information.
Thanks, Tracy. So the next question I see was one about a practitioner interested in applying BPMN, CMM, and DMN on the education side of things and how they get involved. Anna, would you like to field that one?
Absolutely. Join our group. Come to our session tomorrow and you will see how we're actually working on it. In my presentation, I showed the list of business cases, use cases that we have already some experience to work on. Actually, we can show you the workflow for patient registration, for information integrity, for falls in trauma settings, immunization, diabetes, and so forth. Come to our community. We're working in the very collaborative sessions. We're developing this workflow, but more importantly than reaching out outside of our community for validation of this workflow. For example, in Capstone project, students were able to run a validation session with the children in Dallas, Texas, as well as Florida Health Department and Johns Hopkins Medical Institutions to actually validate if identification of victims of child health trafficking in emergency department are happening in this particular way, and if it does, then how public health and other social services agencies could be involved. So it's all based on collaboration, on participation, and I cannot wait to see when your particular business case, use case could be added to our list we're working on right now.
All right, so there's a small clarification, I think, from Lloyd about, as an instructor validation. So let me quickly respond to that. There's one other question I'd like to give Tracy a minute before we wrap. For those that are interested, and one thing I kind of neglected to mention is that the IP coming out of the BPM Plus community is freely shareable and consumable. But we don't own the detailed content around the processes, the pathways, et cetera. So we're focused on the kind of methodology, the underpinnings, the best practices for organizations to then pick up and use. So the idea of the curriculum that's being developed and so on, that would be available, for anyone to pick up and consume and apply in whatever settings you see fit. The barriers to being involved and contributing to this work group, well, Anna is focused on the academic side. The remit for that group is absolutely includes professional education. So, membership is not required to show up on the calls and ask questions and start to engage. So we encourage you to do that. But feel free to take any of the materials here and start to apply them and give us feedback on where you think there are gaps. One more quick question, then I'd like to throw it to Tracy to give a quick tour of the website, and then we'll wrap. It's a question from Dr. Opelka, basically saying that clinicians tend to be familiar with their part of a workflow, but not necessarily the end-to-end workflow or what the responsibilities are of members of the team. Does BPM Plus have any role to play there? And I think the short answer is yes, that by expressing the interrelationship among different working parts as part of the manifestation of a care pathway, it would serve to more broadly inform parts of the team, help clarify where those handoffs happen and what data is needed associated with those handoffs, et cetera. So some of the early wins that were associated with this community came out of, for instance, the American College of OB, where they weren't using executable pathways. They were just trying to manifest how all the integrated picture looks and identified gaps in their existing clinical practice guidelines and errors and inconsistencies that they were able to drive out through the formal modeling. So I think it absolutely has a role to play in addressing that particular challenge. So I'll wrap here and just say thank you to all of you, and we'll give Tracy the last word just to show you where to find some of the resources that are available to you. Tracy, the floor is yours.
Thank you, Ken. Yeah, so I've pulled the website back up again. Our URL is bpm-plus.org. This is our site, and of course, along the top here, the different sections of the site. Probably the most popular area is our resources section. This is where you'll find the field guide to shareable clinical pathways, presentations from our events and workshops, some of the reports, et cetera, that Anna was talking about coming out of the education working group, and we're currently building out our resources. So go there. Events is, we host workshops throughout the year, about 2 to 3. We also partner with other organizations like HL7 and HIMSS. So here's where you'll find events. Now, to get involved, I would suggest you join BPM Plus Health as a member or participant. When you sign up, you can also opt into working groups that are of interest to you. There's 5 working groups. You can also join working groups here under the Participate tab. So either place. On this main working groups page, you see an overview really of how our 5 groups work together. And we have an open call calendar. My computer's freezing a little bit, but that's okay. Under this tab, you'll find our open call calendar to join meetings. But I suggest you sign up, because when you sign up, you get added to our distribution list. And that's the best way to stay informed of meetings. So I think I'll wrap here.
Do you want to mention quickly, just mention Confluence?
Yeah, so our collaboration site, with many thanks to Logica Health, we do have a Confluence instance for BPM Plus. Each working group has a section here once this loads. And this is open access. If you don't have an account just yet, you know, it's read only, but you can create a login, and there's instructions as well once you join BPM Plus. But you'll notice from our main site, we link quite a bit out to Confluence, because this is where all of, you know, the chairs and the members are actively working on projects. You can get there through our website. There's also a couple short links. So here, collaboration site. All right, well, thank you so much for everyone joining us today. Thank you, Ken, Shane, and Anna for speaking. This is our first session. There's 3 more today. The next one starts an hour from now with Davida Satara. It's an authoring spotlight session, excuse me. And if anyone needs the login details, I tried to be good about sending them around, but just ping me. My email is tracy@omg.org, and I look forward to seeing you on there. Have a great rest of the day. Thanks.
Bye all.